soaring high and making difference, where we talk anything about nursing. So let your voice be heard right here. Moments with Professor X. Oh my God, kumusta na kayo lahat? How's everybody? It's me again, Sander. It's been a while. I miss everybody. I miss doing this again. Anyway, how's everybody? Today's actually July 8th, 2025. Would you believe it? We're almost done. Not actually almost done. We're 50% done of 2025. Oh my God. Few months from now, magbeber na. It means to say, magdi-December na, magki-Christmas na. So, in the Philippines, we celebrate Christmas as early as September, right? I can't wait for Christmas. I don't know. I love Christmas so much. I have a good childhood when you talk about Christmas celebration. Anyway, how's everybody? If you were able to look at the caption and the title, we'll talk about traction this time. So big shout out to all my students. Oh my God, I forgot to speak English kasi nga may mga estudyante tayo dito. Anyway, so we'll talk about traction this time. I know at some point, like 2 weeks ago or 3 weeks ago, I started talking about cast and I made a little introduction about fracture. So this will be the continuation. Anyway, if you want me to shout out somebody, hold on, let me check. Hello to Jessrel Fabrigar. Hey, kumusta na? Gitaod na gali Christmas lights sa Ketkay Prof. Really? It's too early for Christmas lights to be installed. Anyway, I can still remember, like, when was that? 5 years or 4 years ago? And I was very excited. Tapos bago pa ako dito sa US, and then I told my fellow staff nurse, "Oh my God, I can't wait for Christmas and winter is coming." You know what? She was really upset when I said winter is coming. So I didn't know what's the reason why she was upset when I said winter is coming. So I made a research about it, and then ang sabi, ang sabi talaga, ang nabasa ko, hindi daw maganda na magsabi ng winter is coming. Bakit? Because when you say winter is coming, it's a bad omen. Like you're expecting something bad will happen. So be cautious when you say winter is coming. So it's not a good thing to say. Anyway, how are you, Jessrel? Saan ka na ngayon? Well, ngayon naka-break kami, and then I'm excited for my from the summer clinical rotation. So I'll be going to I'm not sure if I can say it live, but anyway, I'll be going to supervise. I will supervise student nurses to their pediatric clinical exposure and adult health too. So I will not say what facilities, but technically I will supervise and be with the students as they immerse with pediatric nursing and adult health to nursing. Sabi ni Jessrel, still sa CDO prof. Oh, I miss CDO, and big shout out to my good friend Gif Paguntalan. Hi, how are you, Sir Gif, the CEO, president of Aim to Top Review Center. So if you're in Cagayan de Oro City or somewhere in Visayas in Mindanao, you check Aim to Top Review Center for your review programs if you're planning to take any qualifying examination. May it be for the nursing licensure examination, what else? Midwifery. Ano bang in-offer the gift? IELTS? I don't know. I think IELTS kasama rin. Anyway, hello to Daryl Hernan. We say hi. We will say, John, it's a good day. No winter is coming. Oh, really? Oo nga, no? We don't say winter is coming kasi nga sabi ko it's a bad state. May bad omen daw yun. Na-experience ko yan. Sabi niya, hey, don't say that. Nagulat talaga ako. We were very good and we're friends. Tapos bigla lang siya nagalit sa akin. Di naman talaga nagalit, pero nagbago talaga yung facial expression niya. You're not supposed to say that. So, nagulat naman ako. Buti na lang may hawak-hawak akong ano that time. May hawak-hawak ako na drinks. At na himasmasan yung aking sarili. Anyway, hello to, what is this? Belsima K, is that how you say your name? Hi, sir, watching from Tacloban City. Hello to all students in Tacloban City. I miss you. I won't forget going there like months after months after or weeks after the disaster. Yeah, let as well. Let. Hello to Christy Jane Peñalosa Waminal. It's pang level din yung pilyedo mo ha. Hi sir, watching from Camiguin Island. Oh my God! Na-miss ko yung Camiguin. And speaking of Camiguin, big shout out to good friend, used to be my student. Ngayon parang vice mayor na yata siya. He is the vice mayor of Camiguin. Correct me if I'm wrong. Robert Closas. He was my student before and turned out to be a good friend na rin after the review program. Siya pa rin ba yung vice mayor sa Camiguin? Christy? Anyway. Ano pa ba? And I'm going to London, UK this coming 22nd. 22nd. So for those who are in London, UK or nearby city, please let me know. Hopefully we can meet. No? Drink some tea. Hindi na pala coffee, tea.
Get ready to.
Oh, wait. Oh, hold on. I got to turn it off. Sabi, hi sir, watching from ito. Watching from kami, ginoo nga. Sabi ni Chrissy, yes sir, still Vice Mayor of Mambaho. Oh, okay. So, hindi pala buong Camiguin. Vice Mayor of Mambahaw. Is Mambahaw the city proper? Siya yung city proper ng Camiguin, di ba? Yan, naalala ko yung Camiguin. Those were the days. I used to go there like twice or 3 times a year. Nung nasa Cagayan de Oro City pa ako. Anyway, let's move forward. So we'll talk about traction. Let me share my screen, okay? Anyway, if you have any questions, guys, or any concerns, please feel free to drop a message or send a private message to me. Hold on. Give me like few seconds. I have to make sure na naka-stream ako sa other na platform. Okay, hold on. Hello to my aunt Ira Banyares Pascacio is watching right now. Hello to Daryl Hernal. And what is this? 20 others are watching with you. Okay. There's this one. Share. I don't know if you can see me. Okay. Now, before anything else, where's that? There. So before anything else, just a recap. We usually apply traction or we do traction application to patient with fracture. Okay. So by the way, this is this Facebook Live or whatever you call this stream is intended for those who are planning to take any qualifying examination. So this will not replace whatever medical advice your doctor is telling you. Okay. So anyway, big shout out to my good friend Juan Marco JM. Thanks for watching. And to Juliet Malake Hamada. Thanks for watching. So again, so traction is application of a pulling force to an affected part of the body. So we do this usually to immobilize the body part with a fracture. Okay. So if you were able to watch my video or my stream like a few weeks ago, I started with fracture, and then I talk about cast. So this is the continuation. Okay, just a recap. Fracture refers to break in the continuity of the bone. Okay. So maybe related to trauma or accident or maybe infection. Infection can cause fracture as well. Now, because of the break in the continuity of the bone, you need to realign that. Okay. How? By application of traction. There are several ways how to realign the bone. There are several approaches how to immobilize the bone. So we have your splint application, you have traction application, we have cast application. So there are several ways. Okay. Now, why do we have to immobilize the bone? Okay, or immobilize the affected part. Now, there are several reasons why we do that. Now, first, we need to immobilize the fractured area to decrease pain. Remember, a fractured area, one of the manifestation is that the pain is aggravated by movement. It means to say that when you move the fractured area, the pain intensifies. So, in order to decrease pain, you need to immobilize that. Okay. The second reason why you need to immobilize the affected area is to prevent bleeding or control bleeding. Okay, because if you keep on moving the affected part, then bleeding may exacerbate. Third reason why you need to immobilize the affected area is to promote healing or repair. Okay, and fourth, you need to immobilize the area to prevent added injury. Okay, because if you keep on moving, the more it causes injury in the nearby structure or trauma in the nearby area. So those are reasons why we do immobilization. And I said that there are several approaches how to immobilize an affected body part. I said splint application, traction application, cast application, or even um, reduction. You have your open reduction and closed reduction. So the focus on this Facebook Live or stream is about traction application. So again, traction refers to application of a pulling force. So there are two common ano ba nangyari sa buhok ko? There are two common types. There are two common types of traction. If you can see on this side, if you can see on this side, there are several images. I don't know if you can see the images on this on that side. There's several images. So the affected part is being pulled. Okay. So there are two types of traction. It can be a form of skeletal traction or a form of skin traction. So what is the difference? If the skin is being pulled to realign the bone, the skin is being pulled. So technically, what they do is they apply bandages and then they pull the skin. So that is what they call skin traction. So they put bandages and they pull the skin out. Not skin out, they pull the skin, okay, to realign or to immobilize the affected body parts, such as skin traction. So it's less invasive. In your skeletal traction is different. Why? In your skeletal traction, the doctor needs to insert pins, wires, or screws directly into the bone of the patient, and the bone is being pulled. That's your skeletal traction. So in your examination, what are the things you need to remember? Things to remember here. If the type of traction is your skeletal traction because it's more invasive, there are pins, wires, or screws inserted directly to your bone. You need to do pin care. Okay? And pin care observes sterile technique. Do not forget that. Can you delegate pin care to an LPN, LVN? So this is specific to those who are planning to take the NCLEX. What's wrong with my hair? Okay, for those who are planning to take the NCLEX RN exam, NCLEX RN, not the NCLEX PN. For the NCLEX RN, can you delegate pin care to an LPN or LVN? Answer is no. Okay, but if you supervise them doing pin care, it's okay. Okay, so the key word there is supervise. Okay, next. Now, why do we have to do pin care? You need to do pin care to prevent or decrease the risk of what we call infection. Ooh, what's wrong with my hair? To decrease the risk of infection in the bone, and that infection in the bone is what we call osteomyelitis. Okay. Now, when I say osteomyelitis, the most common causative agent here is your Staphylococcus aureus. And when you say Staphylococcus aureus, another concept that you need to understand is Staphylococcus aureus that is resistant to your methicillin. So that is your MRSA, your methicillin-resistant Staphylococcus aureus. Now, anyway, if your patient has MRSA, okay, if your patient has MRSA, do not forget that common drug given to patient with MRSA is your vancomycin. Okay. Now, please remember that if your vancomycin is given through your parenteral or IV vancomycin, do not give vancomycin too fast to your patient or fast drip because of the likelihood that the patient may develop hypersensitivity reaction, and you call that hypersensitivity reaction as your red man syndrome. Okay? Ay, natatawa ako. I feel I look stupid in the video. Okay, because of my hair. Don't mind my hair, okay? So anyway, so yeah. So what I was saying, do not give vancomycin fast trip because again, of the hypersensitivity reaction called red man syndrome. Okay? And if your patient takes vancomycin, most often we check for the vancomycin trough. You know what is vancomycin trough? Vancomycin trough is the time when the vancomycin in the plasma has is in its lowest level or concentration. So to check for vancomycin trough, you need to draw blood 30 minutes before giving the next dose. And that's the question in your exam. Okay. So again, what is the best time to check vancomycin trough? Check vancomycin trough 30 minutes before giving the next dose. Okay. Now let's proceed. Now, what else? Still about fracture. Oh no, we're done with fracture. Let's. I think let's move forward. Diretso na tayo sa traction. Hello to my cousin Jong Jong Nape. How are you? Okay, here. So again, ayaw niya mag-move. Let's go here. So again, traction, but ayaw niya mag-move. I hope you can see this, guys. Okay, so traction refers to application of a pulling force, right? And I said there are two major types of traction. You have your skin traction, and then you also have your skeletal traction. Hey, Kas, kumusta na? Skeletal traction. Okay, remember I said that the thing being pulled in your skin traction is your skin. That is why if you use a skin traction, less weight is being applied here. Okay, and how much is the weight being applied for your skin traction? Usually it ranges between 5 to 8 pounds of weight. For skeletal traction, since we insert pins, wires, or screws directly to the bone, so you can know and you can really identify that this type of traction can bear a heavy, much heavier weight than your skin. That is why, what is the weight for your skeletal traction? Usually we apply 25 to 40 pounds of weight, okay, for your skeletal traction. And your skin, we can use this, we usually use this for short term, short duration. Skeletal usually for long term, not super, super long, okay? Usually a little bit longer than your skin traction. And your skin traction, in addition, we usually apply this if you want to do intermittent traction application. Okay. Now there are different types of skin traction if you look at the pictures below. So we have here your box traction. You can see that. So what I'm going to do, I will tell you when is destruction indicated and things to remember for your exam. Okay. Indicated. Okay, your box traction is indicated usually to patient with fractured hip. Fractured hip. Okay. Now, how will you describe box traction? Your box traction exerts a straight pull. So see, it exerts a straight pull on the extremity. Okay. Thing to remember in your exam. One common issue with your box traction is foot drop. Okay, look at the foot. it may cause foot drop. So the question in your NCLEX is, what is your priority to prevent foot drop? The answer is you need to put some foot plate. Okay, so you need to have foot plate. So where will you put foot plate? You put the foot plate here, okay, to prevent foot drop. There's a foot plate, but make sure that the foot plate will not rest on the footboard. Why? Because if the foot plate is rested on the footboard, it defeats the purpose of your traction. So again, one common issue with your box traction is foot drop. To prevent foot drop, you put foot plate, but make sure that the foot plate is not rested on the footboard. Okay? Next, another thing. Sometimes a pitch with box traction, we put shock block. Okay? We put shock block. We put shock block. Where we put the shock block? The rule, wherever is the traction, you put the shock block there. So the shock block is placed actually on the foot of the bed. Okay? Foot of the bed. The purpose of your shock block, so the purpose of your shock block is to provide counter traction and at the same time to prevent patient sliding down the bed. So the rule, wherever is the traction, that is where you put the shock block. So it means to say if the traction is here in the lower extremities, put the shock blocks, okay, where foot part of the bed, not on the head part. So can you imagine if this is your shock block, this is the flooring, this is your shock block, and you put the shock block on the head part of the bed. What will happen here is okay, your position will look like, okay, your patient will look like this. So this is the head part of the bed, foot part of the patient, and this is your box traction. You put the shock block on the head part. This is incorrect. Why? It will elevate or raise the head part of the patient's bed. And because of the traction, the patient will slide down the bed. Correct? So the rule, wherever is the traction, you put the shock block on that side. So again, if this is the flooring, this is your shock block, you put that on the K-foot part of the bed. So the position of the patient will be like this. Okay, please bear with my drawing. So the shock block will provide counter traction and prevent patient from sliding down the bed. So the rule, wherever is the traction, that is where you put the shock block. Okay? Now, question. A patient with back traction, can you turn your patient to sides? Do you think the patient can turn to sides? The answer is yes. So how will you turn your patient? If the traction is on the right side, let's say this is the right side, this is the right leg, right? This is the right side, the right leg. So what will you do if you want to turn your patient to sides? First thing to do is to put a pillow, put the pillow, put a pillow between the thighs of your patient to stabilize the affected part and turn your patient towards an affected side. So don't forget that. A patient with back traction can be turned to side. Prerequisite before turning is to place a pillow between the patient's thighs or between the patient's legs and thighs, and patient can turn towards an affected side. I hope that is clear. And again, we apply back traction to patient with fractured hip. Next, Russell's traction. Look at your Russell's traction. We use Russell traction. When is this indicated? The Russell's traction is usually applied to patient with fractured femoral shaft. Fractured femoral shaft. Okay. Now, how is Russell traction different from your box traction? Look, your box traction exerts a straight pull, correct? It exerts, naninibago ako sa aking stylus. It exerts a straight pull. In your Russell traction, the knee of the patient is slightly bent, attached to a sling or suspended in a sling, attached to rope and pulley. Okay, there's a pulley here on a Vulcan frame. So there's a Vulcan frame. Okay, so it means to say that, hold on. In your back structure, the extremity of the patient is extended, okay, straight. In your Russell structure, the knee of the patient is slightly bent, suspended in a sling, attached to rope and pulley on a balkan frame. Okay. Now, if common issue for your back structure is foot drop, what about for your Russell structure? Okay. Common issue that you need to understand for your Russell structure is skin breakdown. Where are the sites of skin breakdown for your Russell structure? Here in the popliteal area. Okay? Popliteal area are common sites of skin breakdown for your Russell structure. Why? Because look, the lower extremity of the patient is suspended in a sling. That is why your priority action here is to prevent skin breakdown on the popliteal. So how will you do that? You may put a padding on the popliteal area of the patient to prevent skin breakdown. Okay. Now, question: can you turn your patient to side with Russell structure? The answer: slightly yes. So how will you turn your patient to sides? Now, for patient with Russell structure, patient can turn side to side, slightly side to side, but not bend body below the waist. Because if you bend your body below the waist, it will pull the line of traction. Remember, this is usually applied to patient with fractured femoral shaft. So if you do that, if you bend your body below the waist, pulling your traction, it may displace the fractured femoral area. Okay, so that is why patient may turn slightly side to side but not bend body below the waist. Okay, next. Another type of traction you need to understand is this one, your cervical traction. And by the way, some book, your medical surgical book, they don't call this cervical traction. Some book, they call this as your cervical head halter. Head halter. Cervical head halter. Okay. Now, when do we use cervical traction or cervical head halter? Your cervical head halter is usually used to patient with spinal cord injury. To be specific, your cervical spine injury. Okay, remember the cervical spine. Okay, it's your first seven or the first eight. Some book it's first seven, some book the first eight. Now, why is it some book it's cervical seven, other book cervical eight? Other book they call it cervical eight because they will add or they included the first pair called atlas and axis. So that makes it cervical eight. Okay. Anyway, so patient with cervical head halter, make sure that there is continuous or you ensure neck spine alignment. Okay. Next, this cervical head halter, so the patient needs to wear a cervical head halter. It's being pulled. So what happens is that it causes skin breakdown here in the chin, okay, chin and the cheek of the patient and on this area. So your priority responsibility here is to maintain neck spine alignment because of the spinal cord injury. And second priority is to prevent skin breakdown. Okay, where chin, cheek, and ears. So what will you do as a nurse? Your responsibility to prevent that is to pad the chin, protect the ears of your patient. Again, because of skin breakdown. Okay, because this thing is pulling the head of your patient to maintain neck spine alignment. Now, can you turn your patient to sides with cervical traction? We discourage you doing that because your first priority is to maintain neck spine alignment. If there's a need for you to turn your patient, make sure that you turn the patient as one unit. You observe log rolling technique. Okay? Now, because the patient assumes this position, there is also risk of skin breakdown on the patient's back, in the lumbosacral area, as well as in the shoulder of your patient. So make sure you need to use an appropriate device, beddings or mattress to prevent skin breakdown. Okay. Now, another type of traction is this one, Bryant's traction. So when do we usually use Bryant's traction? Usually, we use this for children younger than 2 years old. Okay, and used to patient with fractured femur, or to a pediatric with hip dislocations. Okay. So this is your Bryant's traction. The question, what if only one extremity has a fracture? Let's say this right leg has a fracture. Do you really need to raise the other extremity even if it's unaffected extremity? Yes. So in your Bryant's traction, both extremities are actually raised or elevated, even if only one extremity has an injury or abnormality. So both are actually elevated. Okay. Your priority in your Bryan instruction is to maintain flexion, hip and legs flexion about 90-degree angle. So 90-degree angle flexion of the hip and knee. So this is your priority. And make sure that the buttocks of the patient are slightly elevated against the mattress, usually about 2 inches elevation. Okay? So don't forget that. So this is your Bryan instruction. And what else? Usually for Bryan instruction, we apply a weight of less than 35 pounds. Okay, for your Bryan instruction. Okay, common for pediatrics younger than 2 years old. And another type of traction is this one, your pelvic traction. So when do we usually apply pelvic traction? We usually apply this to patient complaining of low back pain. Low back pain. So in your pelvic traction, the patient needs to wear a pelvic strap. So if you can see, let's try to zoom in. Oh. So the patient wears a pelvic strap. Pelvic strap, it is attached to rope and pulley and it is being pulled. Okay. Now, if your patient is using a pelvic traction, don't forget that the best position of your patient is semi-Fowlers with knee bent. Okay. Semi-Fowlers with knee, okay, bent. This is the best position. And one common issue you need to understand for pelvic traction is again skin breakdown. Where are common sites of skin breakdown? Here, okay, ankle of the patient, the lumbosacral area of your patient, and shoulder. Okay, sometimes here in the occipital area, in the bony prominent area. That is why you need to pad these areas or surfaces to decrease the risk of skin breakdown. Okay, so these are common types of obstructions you need to understand. Okay, so just a recap. Okay, so this is your butt obstruction. Okay, issue is your foot drop. That is why for foot drop, I said you put foot plate. And don't forget that the foot plate must not rest on the footboard. And another thing about butt obstruction is your shock block. Okay, now, what else? Russell obstruction. We use this to patient with fractured femoral shaft. So the affected part is suspended in a sling attached to rope and pulley on a balcony frame. One common issue there is your skin breakdown. So you need to pad the popliteal area. Cervical traction, common issue, and usually we use this to patient with SEI. And take note, skin breakdown as well in the chin and ears and cheek of your patient. So you need to protect those areas. And by the way, speaking of SEI, if your patient has spinal cord injury above T6 or thoracic 6, be mindful with a complication called autonomic dysreflexia. And one common factor that triggers autonomic dysreflexia is a distended urinary bladder. That is why you need to insert a Foley cath to your patient. Okay? There are also other factors that can trigger autonomic dysreflexia, like physical stimuli. Okay? Anyway, another priority for patient with cervical traction is to maintain neck spine alignment. Another is your Bryant's traction. We said that in Bryant's traction, this is for pediatric under 2 years old. And then, even if only one extremity is affected, both extremities must be raised and flex 90-degree angle. Okay, so that's your priority. And make sure that the buttocks of the pediatric is elevated or raised at least 2 inches above the mattress. And lastly is your pelvic traction. We usually apply this to patient complaining low back pain. And the patient needs to wear a pelvic strap. And the best position for patient with this type of traction is semi-Fowlers with knee bent. And another issue, same issue with other traction, and that is your skin breakdown. So you need to pad all those bony prominent area to decrease risk of skin breakdown, your pressure sore, or your pressure ulcer. Now, in general, now if your patient has traction, what are the things you need to remember? Okay, where is that? Okay, remember. What are the things to remember to patient with traction? Number one, don't forget this. Your priority, okay? Your priority the moment you receive a patient with okay, with traction. What is your first responsibility? Okay, if your patient has traction. For example, I'm the nurse and I was assigned to a patient with traction. What will be my first priority? What is the first thing to do? The first thing to do the moment you receive a patient with traction is to check or perform neurovascular assessment. Neurovascular assessment. Now, when I say neuro, so we're talking about sensory and motor. Now, how will you check for neuro, sensory, and motor? You tell your patient, can you fan your toes? So you evaluate motor functioning. Okay. Or tell the patient, can you feel this? Can you feel I am touching your toes? Can you, is it warm? Is it cold? Is it sharp? Is it dull? So you're checking for the sensory. Okay. So that's how you check for the neuro status. What about vascular? Okay, what about your vascular? So to check for vascular, you look at the color of the skin of your patient. Okay, is it cyanotic? Is it pale? Okay, is it bluish? So that will reflect vascular condition of your patient. Not only that, you check for the capillary refill time. It must be less than 3 seconds. Less than 3 seconds. Okay, so that's how you check for vascular or vascular condition. What else? You check for the pulses. There must be pulses. Why? If there's no pulse, okay, patient complains pain, and the area is cold to touch, and the skin looks very pale. Most likely, your patient is experiencing compartment syndrome. Okay, so that is the first thing to do the moment you receive a patient with traction. But take note, this is not only to patient with traction. You need also to do neurovascular assessment to patient with casts. Okay, cast. Remember the cast? Okay, remember the two types of cast, the plaster of Paris or the POP, and the synthetic cast or the fiberglass cast. Next, second thing to remember. Okay, for patient with traction, take note, there should be no pain. There should be no pain while in traction. Do not forget this in your exam. The moment that patient complains pain while having traction, most likely your patient is not in proper position. Okay. If the pain is accompanied by fever, warm skin to touch, foul odor discharges coming out from your traction, I'm referring to your skeletal traction, then most likely that is related to infection, osteomyelitis. Okay. But technically, there should be no pain while in traction. Next, number three. Third thing to remember, the line of traction must be along the long axis of the bone. Okay? The line of traction must be along the long axis of the bone. Okay? It means to say if your traction is, hold on, how do I do that? Okay, here. Let's say the traction is on this side. Hey, where are you? On this side, the line of traction must be along the long axis of the bone. Do not put this traction on the other side. Because if you put the traction here, what will happen? The extremity of your patient will go to the other side. So the line of traction must be along the long axis of the bone. Okay? Next, another thing to remember. Number four, and this is very common in your exam. And what is that? Weights must hang freely at all times. So do not forget this. Do not try to lift the weight. Okay, the weight must hang freely at all times. Even if you need to boost the patient up, okay, to the bed, or move the patient a little bit, or turn your patient to sides a little bit, the weights must hang freely at all times. Okay, now patient retraction number 5, what will you watch out for? So this is in general, regardless of the type of traction. A patient retraction, you need to watch out for compartment syndrome. Compartment syndrome. Okay, if you were following me, I discussed compartment syndrome several times. Okay, next, a patient with traction. What will you watch out for? Watch out for skin breakdown. Okay, bed sore. That is why you need to put some padding, put uh some dressing that will decrease the risk of skin breakdown or skin injury. What else? Letter C. Patient with traction need to watch out for DVT. What is DVT? Deep vein thrombosis. Why? Remember, a patient with traction, you immobilize the patient for several days. So that will increase the likelihood of deep vein thrombosis. Okay. Remember that one cause of DVT is immobility. Okay. So if you're immobile, that will affect blood flow or circulation. As a result, that will promote clot formation in the lower extremities or lower pelvis of your patient. So DVT, that is why don't be surprised that patients who are immobile or patients who are not moving a lot, doctors will order DVT prophylaxis. So you'll be given heparin shot, or doctors may prescribe Lovenox shot or enoxaparin shot. Lovenox or enoxaparin, they're the same. Okay. So these are things you need to remember when you talk about traction. Okay. I hope this makes sense. I think we're done. I hope you learned something, guys. If you have any questions, please let me know. Okay. By the way, hello to Marcos Jose, to Ching Hondanero. Thanks for watching. To Brian Leses. Thanks for watching. To Len Vinceline Layson. Lori May Bacon. That's a nice name. Bernie G. Tar. And Love Victoria. Thanks for watching. And Achi Bell. Elaine Ako. Thanks for watching. Okay. So, hope you learned something. Those are just the tip of the iceberg about your traction. Thank you so much, guys, for staying, and I hope you learned something, and I hope that it will help you as you take your qualifying examination. God bless. Keep safe, everybody.